to meet you in person.
Yeah, we're 5 minutes early, you know that?
Let's see.
Should we wait 5 minutes? I think Reina is kind of getting people in. Reina, should we start or wait 5 minutes? Because we're 5 minutes ahead. You should get started? Okay. So welcome to Molecular Tumor Board, and I'm glad to see that this is probably one of the first times we don't have a full manual on the stage, but actually, you know, show a little more diversity and inclusion. Sorry, I just ran in here. I'm very glad to have Dr. Schwartzberg, who I think doesn't need any introduction. I don't have a gift for you right now. I'm sorry, you know, okay, if you'd expected that. Then Amber Fifield from Caris and Lauren Welch from Guardant Health. Lauren and Amber are the ones who help us at West, you know, run our molecular tumor boards. We're alternating from week to week. Lee Schwartzberg was the one who developed these tumor boards. You know, when he left, unfortunately, to Lake Tahoe, to say that, I took over, and since then we've been running these tumor boards, you know, every other week, a liquid tumor biopsy, a liquid tumor board, ctDNA, and a tissue-based tumor board. Okay, so let me get the introduction here with a case that we discuss in our tumor boards. It's an 84-year-old male patient with an abdominal mass. It was actually an inferior vena cava mass noted on CT in summer 2024. And this was supposed to be, again, arising from the vena cava. There was an intraluminal catheter-based biopsy, and pathology showed a pleomorphic epithelioid and spindle cell tumor with indistinct cell borders, were 17 mitosis by power fields, so quite aggressive. Vimentin positive, and conclusion was a high-grade sarcoma. Now, this was sent out for tissue testing, and this is what we saw. And so, Amber, if you can speak, you know, what do you see here?
I've been saving my voice all day, so hopefully I can
use the microphone directly.
Okay. I've been saving my voice all day, so hopefully I can make it through. So when Axel first sent this case to me, it just looked a little strange. Not impossible to have a sarcoma with a TMB of 47, but that just stood out as strange. And then looking at the list of pathogenic and likely pathogenic alterations, it just felt odd. So I reached out to our molecular geneticist on it, asked him, do you see anything in the background here? This isn't looking right to me. And then additionally, I also have access to be able to see what the GPS results are. So GPS is an algorithm that runs in the background, genomic prevalence score, helping us to try to identify what the tumor of origin is. And it was a low percentage call. I think that's the next slide.
Here?
Yeah, it was a low percentage call at 58%, but for melanoma.
Right.
And so I asked him, do you see anything here? And actually he did. So I think next. So he saw a UV signature. So we wouldn't really expect that from...
So what is a UV signature?
Yes, so a UV signature is we'll see specific mutations in the tumor that are associated with UV damage. So what we can see here on the top right is this patient's UV mutational signature. A lot of dipyrimidine typically changes that occur. And at the bottom is an example signature. You can see they look very, very similar to each other. So these two things together were very interesting to then send on to Axel.
Yeah, and I mean, the difference between a pleomorphic sarcoma and a TMB high melanoma is dramatic for treatment. And so the idea came here, you know, first of all, it raised the flag, the TMB was really high, and we don't see that in sarcomas. That is very unusual. Then the GPS signature, this kind of mutation-based signature, what are we looking at? That's, I think, a very powerful tool when you talk about the, let's say, low number of patients that we now see with unknown primaries. You know, you can actually, from the mutational pattern, you can actually narrow it down, and we've used it actually in clinical practice. So Caris runs this in the background, so you can ask for it all the time. I actually order it all the time because I want to see the data. And then what's not reported is signature. Certain mutations, certain, you know, C to T, for instance, you know, mutation that are very characteristic for UV. There are other signatures out there. There's actually a cosmic database, and you see the link here. You can actually talk about these different signatures. And just to give you an idea, there's even a tobacco signature here for tobacco chewing and tobacco smoking. So they have different, it goes beyond just what genes are mutated, but what kind of, mutation you find on DNA level. Amber, anything to add on that?
Yeah, no, that's exactly right. It's the patterning of the mutations as well, not
Lee,
just
what do you think about this?
I think you're bringing up where we're going in,
Yeah.
in molecular diagnostics, which is beyond single gene pathogenic variants or alterations of any type into trying to distinguish pathways and signatures.
Yeah.
And hopefully therapeutics will follow that.
Agree. So, the low-hanging fruit of single gene mutation, fusion, whatever, I think we've dug through that, Now it's signatures, and then, of course, I think we need to talk about methylation at some point. Epigenetic, and I know Lauren is someone who's really very interested into methylation. We'll talk about that. Okay. This got all a little bit reformatted from, I think they, anyway. So this is a second case, is a 56-year-old female
question,
patient.
maybe.
Oh, sorry. Question. Do you have a microphone? Yeah, we need a microphone.
So did anybody do a skin exam on this patient? Because you haven't ruled out cutaneous angiosarcoma by a UV signature.
So the problem, yeah.
Signature in melanoma, this is a myth.
So the problem with this patient was, which we didn't say, it was a patient who was seen in the hospital, never made it to rest, actually pursued best supportive care hospice care right afterwards. How my colleague Tom Ratliff, who saw him, described him, he was a very fair-skinned farmer. So, and he said it's quite plausible that there was a hidden melanoma somewhere, but
It could still be angiosarcoma.
Angiosarcoma?
Cutaneous angiosarcoma has the same UV signature as melanoma.
Interesting. Follow up? Okay, we'll take it. Very good. Okay. So a patient of mine that I saw in early fall this last year, appendix mass, and with peritoneal washings positive for adenocarcinoma, mismatch repair proficient. Came to West, and we did a blood-based test, so-called a kind of a ctDNA test called Caris Assure, and we found a pathogenic POL-E mutation. So this is, now Amber, that's your thing again.
Yeah, so, it stands out on this call here. We can see the pathogenic POL-E alteration, and then taking a look at the blood TMB, which we can't make therapy associations based on that, but just if I go by general feel, 70 is a little higher than I tend to see in blood. So those things stood out to me there.
So what is POL-E?
So POL-E stands for polymerase epsilon. So polymerases are involved in DNA replication, and so that's what's happening with polymerase epsilon as it's going along. It's replicating the DNA. POL-E is unique in that it also has proofreading activity and is able to excise incorrect bases that it has placed. So if you think about perhaps maybe railroad ties being laid, and somebody's laying those railroad ties and then they realize the last one they laid is the wrong one, they can go back and fix it. It's kind of like that. So that's what polymerase epsilon is doing. And so when it's mutated, it seems to have lost that proofreading capability.
And we've known for quite some time, actually, there was some from TCGA analysis from colorectal cancer, because appendix, colorectal, very similar. That's the Cancer Genome Atlas initiative. That there are, there are the normal tumors, then the mismatch repair deficient tumors. They have mismatch repair instability, microcellular instability. There's a group of patients that have, they're ultra-mutated tumors, even higher mutational tumor burden than the mismatch repair deficient tumors. So the POL-E cases, they are mismatch repair proficient MSS, but they still have a lot of TMB. So if you don't have a test that reads it out with POL-E mutation, if there is a patient, colorectal cancer, any other cancer, that has a very high TMB, and you don't find a reason for it, dig into the mutations, because sometimes it's not easy to find. These are all the mutations here that you can see, and you might actually miss the POLE mutation. It's actually there somewhere here. I think it's, is it down there?
That's the
So
one
I
down at
think
the
it's down
bottom.
there. Yeah,
Oh,
here.
no, yep. Yeah, there it is. Yep.
So that's really what it is. So you might miss it. And interestingly, when you have a mismatch hapadeficient tumor, you mainly see frame shift mutation. Frame shift mutations that are actually very immunogenic, create neoantigens which are very immunogenic, whereas POLE mutation are missense mutations, so not frame shift. They were supposed to be not, we didn't know how mutagenic they are, how immunogenic they are, but when you have a patient like this one here that has a mutation in the active domain of POLE, this is what generates, the loss of function here, immunotherapy is actually recommended now as at least consider immunotherapy in NCCN guidelines. Yeah. Okay. Now, I think we've checked, this was the first and only patient with appendiceal cancer in the CARES database that had a POLE mutation.
Wow.
Yeah.
I think
Okay.
so, yeah.
So this patient, we had a tumor board, and so I had this local regional peritoneal studying nodal metastasis. She started on Nivo-Ipi, and the interesting thing is, I could not get this patient excited about this, because when she couldn't really understand what was going on. I was walking in there and said, you have a POLE mutation. And my enthusiasm really didn't translate into her, enthusiasm. It was interesting, yeah. So she actually had no side effects, really, no side effects. And we did scans, and from a scan perspective, she had a very dramatic improvement, actually, of the tumor. And you can see here the mass, really disappeared, from September to December. And interestingly also, she was part of a clinical study where we used methylation markers, quantifiable methylation markers. And I can't tell you what 15,000 means here before she started treatment, but within 3 weeks, 1 dose of therapy, we went down to 0.
Very cool.
Really cool. So I believe, and Lauren, what's methylation?
What's methylation?
Yeah.
Well, I think to tie in actually to Dr. Lenz this morning, he actually kind of came right up to it when he was talking about a multi-omic approach and kind of where things are moving with precision oncology. And part of multi-omics is epigenomics, and aberrant DNA methylation is probably the most well-known of all of the epigenomic features. So this particular panel, I'm not familiar with.
I know, I'm not challenging you here.
No. But, methylation, it's well studied, but it's not something that we talk about a ton outside of MGMT promoter methylation or MLH1 promoter methylation. But we are starting to look at it more to provide more context beyond just what's happening genomically. Like, okay, we have a missense mutation, that's great, we can target it. But also looking at the methylation status, promoter methylation, and then global methylation status. So we can talk more about that, but.
Very good. So it's really also apparently something we can quantify. And that is interesting on a larger scale kind of cancer. It's not one gene we're following here, but how much kind of cancer methylation we find. It's, I think, a very interesting way of monitoring patients. Now, so this patient actually, I saw her this week. Again, she cannot understand, what's really going on. Said, you don't have any evidence of disease, your DNA marker is down, and we still talk about right hemicolectomy. Again, we have a hard time, monitoring these patients. We don't know whether there's still some intraluminal activity. Even PET-CT scan would not be kind of sufficient. She still had some local regional peritoneal implants, at least on the initial scan. So plan is for right hemicolectomy. Lee, what do you think?
I have 2 questions, one for Amber. So if you have a tumor mutation burden of over, what number would you think about there being one of those hyper mutated genes? Like, is 20 or 30? Suppose you did a more limited panel and you didn't do it, what would prompt you to do?
Well, I can really only speak to Caris's testing and what I tend to see with that. And there's a difference between what we see for blood TMB versus tissue TMB. So if I get a tissue case and I see a TMB, just anecdotally, if I see a TMB of over 100, I'm immediately going to start thinking something's going on. Is there a POLE? Is there some kind of signature? Like what am I looking at here? Whereas with blood, that one is a little bit more varied clearly because, like I said, it's not a validated. We can't do anything with it just yet. But as you saw in that instance, like I said, 70 is higher than I tend to see on our assay. So again, it made me think, okay, there's something clearly going on here.
All right. And Axel, just a clinical question. Would this patient have regional metastatic disease? Or?
I mean, it looked, I mean, she had peritoneal washings which were positive.
Oh, peritoneal washings.
Yeah. And local, it was like CT, peritoneal, local regional implants, or lymph nodes. Yeah.
Are you thinking about HIPEC?
Probably not in non-mucinous neoplasm. I mean, so I hope that she's cured with immunotherapy.
Right.
Yeah, that's probably more effective than HIPEC. I always had this idea. Surgeons love HIPEC.
Yeah.
And I like the cytoreductive surgery component. I never understood why surgeons like to sprinkle heated chemotherapy on some tumor cells.
Yeah.
The surgical skill probably matters more. Yeah. Any questions? We did germline. She doesn't have germline. Yeah. Okay, next patient. And this is a patient which I like to, it also leads into something we talked about, POLE, but a strategy, when do we test now? Should we test earlier stage disease? And I'd like to get your input, Lee, about that. So this is a patient who eventually was diagnosed with a pretty aggressive lower rectal adenocarcinoma per PET-CT imaging and MRI, but not metastatic disease. So this was a high-risk stage 3 rectal cancer, and one of our colleagues sent in a tissue profile. So not stage 4, but, and here again, a Caris profile in amber. What do you see?
So there's that screaming TMB in tissue that I was talking about, 139 mutations per megabase, and then at the top we're calling out there a POLE pathogenic variant.
Yeah. And that is, of course, normally, I mean, our mantra at West is, we do not necessarily in colorectal cancer do tissue profiling. I mean, on that level, I mean, of course, mismatch repair proficiency, but not a full next-gen sequencing for stage 3. But and it's not that common. I mean, POLE rectal cancers are not common, but if you never look for them, you never find them. And of course, we had discussions about this patient here, and our MTB recommendation was to initiate immunotherapy, Nivo-Ipi, even though Caris only says Pembro, which we might have to change. Yeah. And treatment started, and here the response. So September, that's a PET scan. December, almost complete response after IO therapy. And patient is scheduled for MRI endoscopy, and this is a patient where we might even consider non-operative management in analogy to the dostarlimab data we have from Memorial Sloan Kettering, where they used mismatch repair deficient tumors, single agent PD-1 antibody for 6 months, and have had a complete response in 100% of patients, and no recurrences yet. Any questions?
Have you adopted that yet?
No, we have not.
Deficient?
Please.
Okay.
I mean, again, if you don't look for it.
It likely will.
Yeah.
Yeah, this is Dr. Manhas. I was just kind of wondering, what do you think about the FDA's approval of, TMB of 10? Or do you agree with it or not? Because I really don't think those patients respond.
I think the TMB of 10 approval for Pembro, that is really what this is about, because there's no POLE approval, that's why Pembro is in there, is not the right thing. It's not the right thing, and I see patients get misled. Reports have to include it because it's important. Patients see the report, say, why don't I get Pembro with a TMB of 11? In a colon cancer, for instance, where we know it doesn't work. It's a waste of it. We need to enroll these patients in clinical trials. I completely agree with your comment here. Yeah. But Lee, the point is really, now, I don't know whether you saw the data at ASCO GI about PIK3CA mutation and aspirin.
Yeah.
I mean, a 50% reduction in recurrence if you have a PIK3CA mutated or PIK3CA pathway mutated altered tumor, which is about 37% of colon cancers, and you get aspirin and you reduce the risk of recurrence by 50%. Should we test every early stage colon cancer for PIK3CA? And if so, why not do a whole panel?
No, just give aspirin to everybody. It'll be much more cost effective.
Yeah,
You don't have a contraindication.
That's the discussion we have. And it's kind of interesting. As soon as you say, because when I have lifestyle discussion with my patient after adjuvant therapy, I include aspirin. I include aspirin and say, hey, you should now the dose would be 160 milligrams based on the data, unless you have a contraindication.
But, I mean, there were previous aspirin studies
Yeah,
in non-selected populations.
They were all retrospective. That was a prospectively selected, randomized controlled trial in Scandinavia. Anyway, and you probably don't hear about it because there's no money-making ability from pharmaceutical industry because aspirin is so cheap. If this was a drug that can reduce colorectal cancer recurrence by 50%, which was, let's say, $10,000 a month, we would hear more about it.
I'm sure some clever pharmaceutical could come up with a new formulation. There's a company called Bayer that I think
Bayer,
discovered it in 1857, I think was the year.
Okay, any other questions? Otherwise, we'll switch to breast and lung, Okay, here, these are questions. We don't know the question. These are, okay, this is your thing. Okay, Lee, thank you.
Okay, so again, I want to thank Axel for inviting me to participate. And I also want to thank Dr. Bettini and Dr. Tower, who shared their cases from West with me so I could present this. So this is a 39-year-old, a woman was 39 at the time of diagnosis of her breast cancer, invasive ductal cancer, and DCIS, ERPR positive, HER2 negative in 2011. She was staged as T2N1. She had 2 or 3 sentinel lymph nodes positive and a 4-centimeter primary. She had hereditary gene testing, and she had a pathogenic variant in BRCA2. And that, as you can see there from the 2011 testing. She underwent bilateral mastectomy and received adjuvant chemotherapy with dose-dense ACT and regional nodal and chest wall RT, and had subsequently a THBSO prophylactically with no cancer found. She was started after that on an aromatase inhibitor since 2012, and she actually recovered very nicely from all her toxicity of a lot of surgery and chemotherapy. She ran a marathon. She was seeing later on GI for abdominal pain, and that workup was negative. That was a couple years ago. And she actually underwent a surveillance MRI of her pancreas due to the BRCA2 mutation in this past October. And the family history, which I didn't put on here, was notable for a family history of prostate cancer and pancreas cancer, but not ovarian cancer. There was also breast cancer in the family. So, just keep in mind that BRCA2 has a wider array of cancers that are associated with it, including breast ovarian, which was termed the breast ovarian syndrome, but also pancreas and prostate. So surveillance when there is a family history is warranted and is guideline concordant. In November, she was admitted to Methodist with chest pain and back pain, and during the workup, she was found to have a T2 pathologic fracture in her T-spine. She then had a PET scan, which confirmed hypermetabolic lesion there, as well as a single relatively large liver lesion. And she went, I think in the hospital, she had a bone biopsy, and the bone biopsy was inconclusive, which is very typical. As you know, sometimes it can be difficult to make a diagnosis, and even more difficult to have enough tissue to send for comprehensive genomic profiling in many cases. So, what would we do now? We definitely need to make a diagnosis. So she went to a liver biopsy, and the pathology showed metastatic carcinoma with breast origin. It was ER positive. It was HER2 negative, but it was 2+, which is now called HER2 low. And the tissue was then sent for comprehensive genomic profiling. Amber, if you would.
So this is very little. I can see it. So with that germline BRCA2 mutation, I'm not surprised to see that the genomic LOH is really high. I think I remember it was 34%. So that goes along with that mechanism of action of what BRCA2 is doing, and when it's not functioning, the scarring that we can see there. And then the TMB is a little elevated there at 12, microsatellite stable, and then I see there's I think a PIK3CA on there somewhere as well.
Can you comment on the, so the BRCA2, I think, was something like 60-something percent. I can't read it. 65% positive. So what range of, and particularly in the context here of the other markers having relatively high BAFs, how does Caris notate that for possible hereditary germline?
So we actually have a team of genetic counselors that reviews the cases. They're looking for a number of specific things. Variant allele fraction is part of what they're looking at, and that can vary depending on what the variant is, but typically somewhere around that 50% range or so. But also the specific mutation, if we do happen to have any clinical history, what do we see? That kind of thing. The tumor type specifically that it's in, there are a lot of things that our GCs take a look at. If they're going to reach out to a physician to notify them that they have a suspicion that it might be germline, because obviously this is a somatic tissue test. We can't say definitively that something is germline.
Does the LOH play a role here in the high BRCA BAF?
It's possible, certainly.
Okay, and then can you just talk a little bit about how we would use genomic LOH here in the context of therapy or
Yeah,
prognosis?
so for those of you who are familiar with ovarian cancer and homologous recombination deficiency, HRD, LOH is a component of that. And so what we're seeing here is part of that, the total HRD signature. So we're seeing LOH high at that 34%. So the potential, we see the scarring that may indicate a potential benefit to a PARP inhibitor.
Okay, great, thank you. So the BRCA mutation was in fact the hereditary. The nomenclature is a little different, the way it's reported here, being both protein, but it was a 4 base pair deletion, same one. So that was the hereditary one. And that's just the summary. So I don't know if you want to make any comments on the summary slide.
No, I think we've pretty well, because no, I don't think I have
But it's remarkable to see how many treatment associations you have here. I mean, for me as a non-breast cancer person, it's always kind of difficult. How do you sequence things? You know, what do you prioritize? I mean, you have SASI, you have TDXD, you have a lot of things here. And I mean, that's all the challenge that I have from outside, and that's why we need breast cancer specialists.
Well, I'm glad you asked that question, because what is the best first-line therapy here? So this was actually from a nice summary that Hal Burstein did at San Antonio, so I lifted it from him. And a couple of points I want to make here is that, you know, as we talked about this morning, we were early adopters at doing first-line genomic testing in all cancers. And we got a lot of criticism, particularly in breast cancer, like, why are you doing that? There's no drugs for this today. We're going to make the decision. And we said, well, and I actually go back to what Axel taught me many years ago. In fact, the very first time I invited him to talk before he came to West, he showed a beautiful slide of, and a concept of, make the treatment plan across the continuum of, in his case, colorectal cancer. So that you're not thinking about it in a discrete module, like here's what I'm gonna do first line, and then I don't know what I'm gonna do second line. What you do first line influences second line. Of course, today with so many more therapies, that's almost self-evident, but it hasn't always been. So today, however, we're in a situation with breast cancer where we do have first line treatments that are genomically based, and that's the point that's made here. And it also makes the point that what they got before in the adjuvant setting influences their first-line treatment. So in breast cancer, we have to know what was the adjuvant therapy in HR-positive, HER2-negative cancer, and we have to know what the genomics are, because actionable mutations now include ESR1 mutation and mutations in the PIK3 gene or AKT pathway. And then as we go further, as Axel mentioned, there's multiple, the algorithm gets very wide and multiple choices. So this patient actually, up until very recently, would have been treated with, if you look down on the bottom, had previously been on an AI, actually failed while on an AI, although, you know, she's been on an AI for over 10 years, and would should have fulvestrant and CDK4/6, which is, has become the standard therapy over the last decade. But we have other options today. So I just want to point out a couple of those. INAVO120 was a first-line treatment in hormone-resistant patients. This patient would, by definition, was HR relapsing on endocrine therapy in the adjuvant setting is primary, actually, endocrine resistance, and had a PIK3CA mutation, so would have been eligible for this trial, which is an INAVO120 testing the standard palbo, ciclib, and fulvestrant versus palbociclib, fulvestrant, and inavolisib, which is a CDK4/6, I'm sorry, which is a PIK3CA inhibitor. So for the first time, triplet therapy in the first-line setting in this large group of patients. And here was the data. So as you would expect in these patients who are inherently endocrine resistant, they don't do well with the standard therapy. In fact, you can see the PFS is really pretty low for this group, for the standard palbofulvestrant, and doubled with the addition of inavolisib. And here's the overall survival at a relatively early interim analysis, but there's a strong trend that by starting with the most effective triplet therapy here, you might actually impact survival down the road in these patients that often get multiple lines of therapy, 5, 7, 8 lines of therapy. And this was just approved in October after endocrine therapy, including after adjuvant therapy for HR-positive, HER2-negative metastatic breast cancer with PIK3CA. So likely in this patient, that's what I would have picked because she was failing on therapy. And these patients, and especially with visceral disease, I think they do the worst. And then if we didn't pick that and we went with, which is perfectly reasonable to go with fulvestrant and CDK, then we also have another drug, capivasertib, which was tested in Capitello. This is a little broader. This is for any patient. We were talking about pathways. So this is any mutation, or the 3 major mutations in the AKT pathway, which is PIK3CA, AKT, and PTEN. Any of those patients were eligible. And this is in the second-line setting, and most of these patients had prior CDK, and you can see that there was more than a doubling of PFS in this case as well, and it worked well if they had prior CDK or not, and also if they have liver mets or not. So this was approved about a year ago, so that's the second new agent in just a little over a year for this group. And now, this patient has lots of targets, as you saw from Kara. So now we just talked about the first line, or maybe the first and second line. What would be the third line? I already know what her third line therapy is going to be. Hopefully it'll be a decade from now. Could be. Right. But I already know that at least if she hit third line today, she would get a PARP inhibitor because she had a BRCA2 mutation. So she's still staying on oral therapy, no chemotherapy. We can expect several years of treatment. This is an oral drug, next line of therapy. And then actually have the fourth line of therapy, which is trastuzumab deruxtecan, also in the first line after germline mutation, or if you have no germline mutation, you have HER2 low. So right now, 4 lines of therapy. We haven't talked about regular chemotherapy yet. I've been in my new practice 3 years, and I was sitting down one day dictating notes, and I realized I don't have a single patient with metastatic breast cancer on chemotherapy. Now, they're only 3 or 4 years out, but they were, most of them were still on CDK4/6 and endocrine therapy. But no one, they were the others, including the triple negatives and the HER2s, were all on ADCs. So it really has changed therapy. And this is the data for for trastuzumab deruxtecan, which showed in the HER2 low group, this is in first line meaning first line chemo, and more than a doubling of the PFS in these patients. And that was approved a week ago. So you can now use this in first line patients, including ultra low, which I won't even get into today. All right, the next, Axel, any comments?
No, I mean, it's amazing. It's really amazing to see how many treatment options you have. When I was still treating breast cancer, most of my patients after, 1 line of tamoxifen were on chemotherapy.
Right.
Yeah. Yeah, that's a long time ago, though. Yeah.
Okay, the next case is a lung cancer case. This is a 51-year-old non-smoker female who came in with pleuritic chest pain And CT and PET showed a hypermetabolic mass in the superior segment of the left lower lobe. It was adjacent to the pleura, but not clearly involving it. She had a previous gastric sleeve and cholecystectomy. She had a CT-guided biopsy which showed adenocarcinoma with focal micropapillary architecture. That's a poor pathologic sign in adenocarcinoma. She had an EBUS, which was negative, so she was felt to be resectable, and she went to a lobectomy in 2021. But at the time of her surgery, she actually had advanced disease with pleural implants and even diaphragmatic implants. So she was stage 4 at that time. So what to do? And Lauren, do you want to talk about it?
Oh, sure. Spoiler alert, genomic profiling was done.
Yes,
and that kind of,
so the thing to do is genomic profiling.
yeah, so that kind of leads us into this part of the discussion. Looking at the various mutations now that we have, this is primarily for lung adenocarcinoma, and there's actually, the pie shows both Asian populations in the outer circle and the Western populations in the inner circle. You can see the prevalence of these different oncogenic biomarkers, which have various therapies, primarily in the first line, some in the second line. But we see more EGFR mutations, increasing prevalence in Asian populations, whereas KRAS mutations, like Dr. Hirsch talked about earlier today, more prevalent in Western populations. So this is just kind of showing you what to expect or how often you may see some of these biomarkers when they present in your practice.
Great, thank you. So her CGP showed, and we'll show it in a second, an EGFR exon 19 deletion. This was on tissue. Her PD-L1 was 5%. MRI of the head was negative. She was started on osimertinib, as you heard earlier, really been a transformative drug in EGFR mutated lung cancer, and she did very well. Over 2.5 years later, she still had stable disease in her left chest, although it was not a complete response, and she had a liquid biopsy for monitoring. So you could talk about that.
Yes, this was back in 2023. The first thing I noticed about this report is that we have 2 different tests for genomic profiling at Guardant, and this is the Guardant 360 CDX, or the companion diagnostic. So it's a companion diagnostic for osimertinib, and it's a smaller genomic panel. So it's 74 genes. So you can see the EGFR deletion insertion P, exon 19 deletion mutation with various EGFR directed therapies in green, which just basically means those are all approved therapies in the indication. Erlotinib, gefitinib, both in red, suggesting there may be a lack of response. This also puts me in mind of Dr. Hirsch's presentation earlier today, where he showed how we have really expanded our understanding of EGFR mutations in lung cancer, where not just the classical EGFR with exon 19 deletions, the L858Rs, but PAC mutations and exon 20 insertion mutations. And this one in particular is a rare exon 19 deletion. So even within the exon deletion bucket, we have rare deletion insertion mutations. In this case, an insertion of a proline. And the reason erlotinib and gefitinib is listed in red here is there are some preclinical studies as well as some retrospective analyses that have shown this alteration in particular, the first generation EGFR TKIs tend to be less sensitive.
Just points to, or Axel, you want to talk
I mean,
about
so the interesting thing here is, first of all, the power of liquid biopsies is sequential serial testing. I think, you can really monitor, and, Ram, if you want to, because you're a patient, that I think you can really see resistance mechanisms evolving, persistent, clones that you have. And, in particular in lung, where you start, testing very early. When we struggle with this, true, we do it in colorectal cancer. In lung cancer, you have done it for quite some time, and, because you have treatment options. And I believe, actually, if I had to rewrite the books right now, it's like a diagnosis of lung cancer, tissue and liquid testing at the same time, and then you go on and you monitor patients, and I hope this is going to be true for all tumors, including germline testing. I think, in 5 to 10 years, we're not even talking about these things anymore. We do germline, we do liquid and tissue at the same time.
I agree. Okay, so she actually had no hypermetabolic lesions, and However, just a couple of months after a PET scan, she did progress clinically in her left chest, had a new pleural effusion. She was tapped, her cytology was positive, and she began carbapenem and continued osimertinib. Perfectly reasonable choice here. That's based on the FLORA-2 data, which was in the first-line setting, but showed the safety and efficacy there. And she did have a response to that, and by June, she was still improving. However, in November, she had new bony metastases in T8 in the left pelvis, and they progressed to symptomatic in January with another new lesion with pain, and her liquid biopsy was repeated.
Yeah, so a few more things on this report. The biggest thing that I first noticed is that this is a different panel. So this is our Guardant 360 panel. I know they sound a lot alike. It's confusing. But this one actually covers over 700 genes. And we do have, obviously, new genomic findings. The same EGFR exon 19 deletion insertion mutation that has been there from the beginning, now at 1.5% variant allele fraction. We now are detecting a TP53 mutation, KRAS amplification, and then maybe most interestingly, BRAF V600E, which was not detected before in blood or in tissue. Additionally, you can kind of see here on the bottom right, as well as the tumor response map, how EGFR was really the only thing previously detected in blue, and now the additional alterations and clones are represented by the different colors. There is a methylation tumor fraction of 0.8%. MSI high remains not detected, and TMB just over 20.
Thank you.
So can I ask, so when you look at the composite, the variant allele fractions, that are reported out here, do you believe that the EGF receptor clone is still the dominant one and the BRAF mutant clone is a subfraction, subclone? And how does that influence your treatment decision?
Yeah, if we go back to the last slide, I think the EGFR, it was 1.5%, the BRAF V600E 0.2. It's actually very common when patients are developing resistance and a new alteration is detected. EGFR tends to remain the driver, like the driver clone for these patients, even when the VAF decreases. The BRAF V600E being 0.2%. Obviously, we can't know without sticking a needle in every bone lesion and seeing if BRAF is there, but you could infer, given the clonality, that this isn't a subset of resistance that's starting to emerge.
And one of the advantages of liquid biopsy is you're seeing, in a sense, the total picture and not just relying on an individual biopsy of a single clone. And as we use more targeted therapies, we see more mixed responses as clones develop in one particular metastatic site, not another. Dr. Hirsch went over this in detail, so I won't. There's many different mechanisms of required resistance to osimertinib, and this is clearly our problem in 2025. Cancer cells are smart, and they have different ways of overcoming mechanisms. So here's where we are today in EGFR mutated non-small cell lung cancer after resistance to osimertinib, and it can be broadly 3 types that we're aware of, as well as others: on-target mutations, bypass mechanisms, and histologic transformation, and many different options for therapy. In this particular patient, she had the liquid biopsy you saw, and the plan, as I understand it, is for dabrafenib, trametinib, and osimertinib. Dabrafenib and trametinib are a combination that targets the BRAF gene well, and continuing the osimertinib, since, as we talked about, it remains a driver, as well as palliative radiation. And this is just some data, and we're really still at the case study level of using a triplet therapy, and this is one study that showed some really nice responses to this post-progression on osimertinib by using this 3-drug combination in dual EGFR and BRAF mutated. This is another study that also retrospective review. So small numbers of patients, individual, so still not in the clinical trial level, may never get there with the number of patients, but it's certainly a very reasonable approach to do this triplet therapy for this patient. And the last thing, as also was mentioned this morning, is ADCs are coming in lung cancer, and there are multiple targets for ADCs and multiple drugs that will be imminently or approved for this, so give us a whole other landscape of treatments. So we will go through that.
Okay, very good. Very good.
Thank you.
Any questions? There's a question over there.
We'll do a few questions.
Going back to the first case, the lady that was on protracted adjuvant hormonal therapy, do we have good data going beyond 10 years as of any benefit? And if so, what is the role of breast cancer index testing in that situation? How do you pick those patients?
Yeah, that's a great question. So I'm not sure what the rationale was for here. I didn't have the full record, but what I do in my practice is in patients who I would consider high risk or intermediate to high risk, after 5 years of endocrine therapy, consider them for additional therapy. There is data, multiple data sets now that show extended adjuvant therapy does have some benefit. I do use BCI or MammaPrint now also as two very good tests for determining whether there is benefit from extended adjuvant therapy. So typically, when we get to the 4-year mark, if the patient is tolerating it well and I think they're high enough, I've usually introduced it, like we may think about longer therapy, we'll see how you're doing, and then we do the test and make a decision on that.
I was going to say, I've had maybe a handful of patients with 10+ nodes that I'm going to treat until.
I agree.
But other
ultra high
than
risk.
that, I stop everybody at 10 years at the longest, and maybe even at 8 with the data that showed that 8 may be as good
There
as
is
10.
there's the MA17, the original study of 10 versus 5 was actually re-randomized to 15 versus 10. And so we actually have prospective data there, and there was about a 1.5% benefit in IDFS in that study. But of course, the converse is more fractures when you're on. So there's certainly reason to consider even longer therapy in those patients.
Perfect. We'll have one more question.
How many patients with germline BRCA2 will have high LOH status?
For you.
That is a great question, and I don't know the answer to that off the top of my head. So I would have to, if I can get your contact information, I can certainly look that up and let you know, unless somebody in the audience happens to know that on the top of their head.
Just what I see anecdotally, when we look at our molecular tumor reports, just something fell off. I'm breaking the mic here. Yeah. So BRCA, even germline BRCA2 mutation, do not always correlate with high LOH. And sometimes you see, high LOH, and you really try to figure out and we have these discussions, where is this mutation that is causing something in HRD, and we don't find it, So I consider LOH a little bit still, at least in a lot of tumors, a soft marker and not a very solid marker right now.
2, is high LOH predictive for PARP inhibition therapy? If you have high LOH status, would you jump to PARP inhibitor over, say, PIK3C mutation targeting or something like that?
When high LOH, whether you go for PARP inhibitor, I think it's only validated in ovarian cancer and not in any other cancer. So I would think we need more data, in other cancers where PARP inhibitors could play a role.
Yeah, I think HRD has been elusive in terms of a definitive test to help us make a decision on that. And so that's still an area of controversy and research.
Thank you so much.
Okay. Thank you.